and dietetics. And in the blue corner, we have Dr. Nyawera Maina, who is a general practitioner in diabetes care. So she's the one who actually manages the patients. She sees them on a day-to-day basis. So she has a lot of information to share with us. But we may be concerned. I think we need to mute that person, Anthony.
Anthony?
Yeah, I'm doing that.
And carry on, sorry about that. Oh, did we lose Lorraine?
Yeah, we lost her, but she's coming back.
Sorry, I think I must have muted myself instead. Sorry about that. Okay, so we were asking about diabetes, why it's such a concern to most of us. Well, diabetes is a lifestyle disease, and it's common in most families. I'm sure some of us here may be having a family member who's suffering from diabetes, if not we ourselves. And what's more, as we grow older, then we become more susceptible to contracting diabetes. I would say for me, it's very personal because I lost my uncle several years ago to diabetes, and my dad as well is managing diabetes. And so it's personal. I'd like to know what I need to do in order to help in my family. I'm sure like most of you here. But what are the statistics about diabetes that makes it even more concerning? Did you know that every few minutes, one person dies out of diabetes complications? What's more, the prevalence of diabetes is 460 diabetic cases per 10,000 population in Kenya. Across the world, according to World Health Organization, the number of people with diabetes rose from 108 million in 1980 to 422 million in 2014. That's a very big number. It keeps rising. Interestingly, the prevalence of diabetes is more in low and middle income countries than in high income countries. Additionally, between 2000 and 2019, there was a 3% increase in the mortality rates associated with diabetes. Something else, in 2019, diabetes and kidney disease caused an estimated 2 million deaths. So those are big numbers, and this is what's truly happening on the ground, both in Kenya and all over the world. So you do agree with me that diabetes is a major concern. So then, how will DCLP help us? How will it help you? How will it help your family to prevent diabetes? Is it able to help us reduce the medication that we use for those of us who have diabetes? Or better still, will it help us to reverse diabetes? Well, to know what the program is about, we'd like to invite Dr. Ojwang to set the pace and just help us cover the topic DCLP, or Diabetes Control Lifestyle Program. What is it about? Welcome, Dr. Ojwang.
Okay. Thank you very much. Thank you, Lorraine, for the kind words and introductions. Today, we're going to share with you about Diabetes Control Program. Why Diabetes Control Program? I've been working in diabetes and nutrition and diabetes for a very long time, since I finished the university. I worked in Kenyatta National Hospital, and I realized the only people who actually did very well were diabetic patients. I saw HIV, TB, and all these people. But the ones who did well, and we know that if actually managed them very well, they came malnourished, their sugars were out of control, they would actually do well, were diabetic patients. So that motivated me to love to actually manage diabetes. And I remember the first time I told one of the endocrinologists that I really wanted to work in diabetes and obesity. And so he invited me to go for a meeting in a Pan-African hotel. And that day, all the physicians in Kenya, they were having a meeting about diabetes and obesity. And there I started learning about diabetes. I think the first time I met Dr. Ivan Jenga, who's one of the diabetes management giants, was there. So this is how my love for diabetes management started. And why the group wellness program? Having managed diabetes for a very long time, I realized that when people work in a group, people actually do better. But let me start by telling you what my story is. When I started to like diabetes, and I was training as a nutritionist who's managing people with diabetes. I worked in a clinic in South Bay with a diabetic nurse then called Jean Sure. And so I was learning how to, what is diabetes education, and just seeing patients with that, and just learning and reading really as a nutritionist, And so what happened is companies used to bring their machines to be tested by Jean. They would bring a machine, like 2-3 machines, and so she would test the machine in different patients to see the blood sugars. Are they different, so that she can make a recommendation. And so this particular day, they were testing the machines. And when she tested my blood sugar, it was 9. I remember very well. And it was maybe like 3-4 o'clock in the afternoon. I had eaten at about earlier on in the day. And she told me, "You're diabetic." I said, "No, it's not possible. I cannot be diabetic. I'm too young." I was 23 years old. And so she told me, "You are diabetic." So she told me to come tomorrow morning fasting. Before I eat anything, then she can take my sugar. When she did my fasting was actually 10 millimoles per liter. This was actually diagnosis for diabetes. Of course, I cried myself stupid. I cried so much. How is it possible? Already, it's very hard for me to take medicine. Even just taking, painkillers for a headache, taking multivitamins. I'm not the type to swallow pills. So I was imagining I'm going to take all this medication for a very long time. So what happened anyway, I was started on medicine to control my blood sugar. And so she also took me through diets. And of course, as a nutritionist, let's say I was fresh from university, maybe a year, been practicing for a year. And I didn't know really so much about lifestyle. And so we went through lifestyle, and I controlled, change my diet. At that young age of 23, you can imagine what happens. Late nights, dancing, alcohol, junk food. I was living alone, so obviously not cooking and just eating maybe bread, and not quite healthy actually. And so what happened, I completely changed my lifestyle. I started applying what I studied in school. I cooked my meals, I ate meals. I applied some of the basic things I always tell people: ate more food in the morning, less food in the evening. And I exercised, I stopped taking sugar, juices was not part of my diet. I removed anything from my diet. Of course, at the beginning, I was extreme because I was scared. I couldn't eat any cake, nothing. And even I would tell my patients, no cake, no that. But then 6 months later, I was now getting low blood sugars, hypoglycemia, low blood sugar on the treatment that I was given. And then now she had to reduce, the medication was reduced. I was being seen by the nurse and another physician. The medication was reduced. And then after 3 months, another 3 months, which means 9 months, they actually removed the medication completely. And that means, she told me, "You've not reversed type 2 diabetes," which is the common language. She says you're still diabetic, but on diet and exercise. So if you change your lifestyle and start eating unhealthy and go back to your old lifestyle, you're going to start taking medication again. So ideally, it had gone on remission, or it's called honeymoon. So for the last 24 years, I have not been on medication for diabetes. And learning that at an early age in my career helps me to believe and to know that you can actually reverse type 2 diabetes. Type 1 diabetes cannot be reversed because it affects the pancreas because of an autoimmune condition, but type 2 diabetes can be reversed. And so it really depends on your lifestyle. For a long time, I started running my clinic officially in 2001, and I was right next to Dr. Ivan Jenga, who's one of my mentors and who's helped me to be where I am today. And we used to actually, a lot of times, she'd send patients, they lose weight, their medication reduces, sometimes they'll be put off medication with monitoring. If they change their lifeline, they go back. So for a long time, we've been doing this. And so why am I here today? I wanted to share my story and also to encourage you, if you're diabetic and hypertensive, yes, you need to take medication to control your diabetes. But you find that some people actually take so much medication. If you're not eating properly, you're not sleeping properly, you're not exercising, you cannot control your blood sugar. Your blood sugar will constantly be high. And because you're not changing your lifestyle, the doctor's goal is to control your blood sugar. So they will prescribe more medication to control your blood sugar. And if it goes out, if you're really that bad person who is not even listening to the doctor because they will tell you, go see the dietitian, then they will have to give you another pill to protect your kidney, another one to protect your heart. Then you start getting a lot of infections, you're given more diabetes, and before you know it, you're taking maybe 10 tablets a day. Just say 10 tablets a day times 30 days. You're taking 300 tablets a month. That's about this much. So if you're going to be taking 300 tablets a month, how about 1 year? You can imagine you will just struggle from the side effects. So we are here to just tell you diabetes can be managed, it can be controlled. There are so many clients who have been diagnosed with diabetes, they've managed, some are on low doses of medication, some are not on medication, but with diet and continuous monitoring. So you can do it. So the control program, the diabetes control lifestyle program, it's a program that's going to help you to learn lifestyle skills. And some of these lifestyle skills to understand, as a diabetic person, why must I follow a proper diet plan? And it's not a diet where you're told eat this and stick to this. No, it's really flexible, but you have to learn the tricks. The tricks like carbohydrate intelligence. What is carbohydrate? Okay. Sometimes I tell patients, you can't eat rice and beans. And so then they are like, no way, beans is protein. But if you go and Google beans, beans is 60% carbohydrates. And we know that when you're diabetic, when you take food, it becomes sugar. 60% of your protein becomes sugar, 100% carbohydrates become sugar. So when you have 2 carbohydrates in one meal, you have rice and beans in one meal, it's going to shoot your blood sugar. But that we are going to be talking about in the session of nutrition in diabetes management. The lifestyle program will teach you lifestyle skills to be able to manage your diabetes, including diet, including exercise, including circadian rhythm and sleeping, physical activity, and of course, we'll also include the endocrinologist, the ophthalmologist, the psychologist, and even the renal physician and the podiatrist. You know that a diabetic patient, if you have a sore and you scratch it and you don't manage it well, it can actually end up in amputation. So we'll be having a podiatrist in the session to tell you how to manage to take care of your foot. A psychologist with diabetes, we get some of these emotional ups and downs. The psychologist who specializes in diabetes will explain for us as a diabetic person, what you need to do so that you can just live a normal life. We know some of the complications of uncontrolled blood sugar is you can go blind, you can get a kidney problem. And so we will have an ophthalmologist and we have a renal physician to just give you the tricks of how you can actually manage so that you don't get complications. Then, of course, diabetes affects your life. It affects your sexual health. It affects your, generally for some people, they don't know how to manage that. It affects how they live their life. They can't go for parties. They can't live a normal life, and in the family, or maybe they're the father or the mother in the family, they eat a different meal from the other. No, with diabetes and good control, you're not supposed to live like that. You're supposed to eat with everybody, but you have to learn the tricks. And so this is what you're going to tell you. And of course, this lifestyle skills includes your, sleep, circadian rhythm, sexual health, and also your specific needs. We also know that some people are diabetic, but they don't only have diabetic, they have high blood pressure, they have high cholesterol, and they're also overweight. So the program is going to be able to address this. Just remember the saying that goes like, knowledge is power. And this is what the program is going to do. And with a group wellness program, you get support from everybody else. You're not alone. You're with people who have the same condition, they have the same challenges that they're struggling with, and together you can overcome it with support from the whole health team. So every week we'll have a session and we will tell you what to do this week. And then the next week we'll have another session. So we give you every week, you get a challenge that you need to do, or a lifestyle skill that you need to work on, or some knowledge on how to improve your diabetes better. And we've done this, and we have so many people who have done very well. And I hope that some of them are here to share with us. So I can stop here and take questions, but what I want to remind you is, remember, the genes load the gun. Maybe your parent was diabetic, maybe your family are diabetic. Yes, the gene will load the gun. Your genes will give you diabetes, but your lifestyle is the one that's going to pull the trigger. And so the diabetes control lifestyle program is to help you so that you do not pull a trigger on yourself. Thank you very much. Over to you, Ms. Lorraine.
Well, thank you very much, Dr. Ojwang. Interesting, isn't it? So you don't have to be condemned to medicine, 300 tablets a month?
No, you can take minimal medication, or if you're fortunate, you can put it on honeymoon, and you can manage your diabetes on diet, exercise, and lifestyle. Yes.
And you don't have to live a boring life separate from the family?
Not at all, not at all. In fact, that's not good, because that makes people so depressed. They feel, they feel distressed. You can't eat with your family, or you eat different food. And that's not what it's supposed to be. But when people don't know what to do, that is what they do. And then life just becomes really not good. You feel sad. Yeah.
And I think something else that stood out for me, you said we will get introduced to different doctors in different lines of medicine to help us to manage, or let's hope at best, reverse the condition. Did I hear right? Oops, okay. Yeah, you know that I had right. Okay.
Yes, you had me well. And we have Dr. Ivan Jenga on here. We also have Dr. Nyawira. And please, you can ask questions before we go on to the next session. Thank you. I'm getting my water, sorry.
Okay. So in that case, if anyone has a question, then I think Dr. Nyawira or Dr. Jenga will field the questions. So anyone with a question so far?
I'm back.
So far, so good?
I think they're satisfied.
Okay, great. I think we are still trying to get our footing. So we go on and we shall get to know even more. So now let's listen to the other expert. Thank you very much, Dr. Ojwang. That's enlightening. At least it makes us know why we should join the DCLP program. I see one question before we proceed, and that is from Jane Owiti. What is your question, Mama?
I couldn't get I couldn't mute myself anyway. That's why my hands were not, I'm using a different device. That's why I delayed, and then you started to proceed on. Anyway, my question is, what about if you are on the borderline of diabetes, but is, you call it 2? Yeah, diabetes 2. What can one do who is on the borderline?
Okay. Thank you very much. Is Dr. Nyawera, are you going to help me, or Dr. Ivan Jenga?
Good evening, everyone.
Good evening.
Basically, if you're on the borderline, you're at a much better place, because with education, with nutrition, you can reverse your diabetes. I mean, that is when we normally would want to catch somebody who's pre-diabetic, because then with proper nutrition, proper advice, you're able to reverse. If not, if you don't follow what the steps, then you come back when you're full-blown diabetic.
Thank you.
Thank you, Dr. Nyawera. I remember in a training I went for, is it Dr. Ivan Jenga who calls it optional diabetes? So when you're on the borderline, it's optional diabetes. You have an option to do everything to make it go away, or to sit and do nothing, then you become diabetes. So you have an option. So when you're on the borderline, you're at a better place, like Dr. Nyawera has said, if you manage your diet, your exercise, and lifestyle. But if you don't manage your diet, exercise, and lifestyle, then you're going to live long enough for it to actually become full-blown diabetes on medication. Thank you.
Okay, thank you very much. Thank you for that question.
Thank you very much.
Okay, good. I saw there's a question, but I think it shall be addressed. That is somebody with a beautiful name. I think it ends with Kisaka. So he's asking about juice, freshly blended juice versus fruits. And I think there's a session that will address that, Mr. Kisaka. So you just hold the thought, it shall come out.
Yes, please.
All right. Since I don't see any more questions, then why don't we now listen to Dr. Nyawera Maina. And Dr. Nyawera is going to talk to us about diabetes care and teamwork. She's the one who's always managing the patient, so let's hear from the horse's mouth. Welcome, Dr. Maina.
Thank you, Lorraine. Good evening, everyone, again, and thank you, Alice, for inviting me to this session.
Okay, would you like to increase your volume a little bit, please?
And would you like us to, we'd like to see you, Dr.
Let me hope the video comes on. I've put it on. I hope it picks.
It's loading. Okay.
It's loading.
But as we're waiting for that to pick, I wanted to basically diabetes, although we say it's a lifestyle disease, it's a chronic disease as well. And rightfully, as Alice has said, type 2 diabetes is reversible, not in everyone, but even if it's not reversible in some people, the drugs can be reduced to, minimal amounts if the diet is followed. Now, the patient is always at the center. So when we say it's a teamwork, the patient is always at the center. So there'll be the patient, there'll be the doctor, there'll be the nutritionist, there'll be the family and work colleagues. So we can't forget that at everything, when we talk about diabetes, we have to take the patient as the center. Now, most diabetics, unless you're seeing a doctor or a nutritionist who's diabetic themselves, they may feel we don't empathize with them, we don't understand them. It therefore becomes important to have group meetings, because you're now talking to diabetics in a group who can be able to share experiences. It always empowers people, whether you're diabetic or whether you're in another forum where you all have a common denominator, it will empower you to be able to share common things. It doesn't mean that what works for one person will work for another, but one is able to gather information from what one person is doing to help them. Now, it's not that diabetes, we don't start talking about, yes, it's a disease, but even if it's a disease, one can live with it until an old age. Yes, we do have patients who are above 70, in their 70s. Some are on insulin and they're living a full life. So nobody should condemn a diabetic because you're diabetic, you can't work, you can't do this, you can do everything. If you Google, you'll find athletes who are diabetics and they're doing very well. So even in our setup, with what we have, and we have a lot, we can be able to manage. So when we talk about having group meetings, you'll be able not only to share the experiences, you'll be able to encourage, you'll be able to empower each other, because you then know you're not alone, you're not walking alone. There are diabetic groups in Kenya, which we will put on the forum, and one can join, because these are groups that help each other. Although we're meeting here, out there in our country, there are also groups. It also gives you a sense of being understood, because now you're dealing or you're meeting with other diabetics. So even as you share, even as we as health professionals should also care for you, listen to you, not just prescribe medications, not just tell you do this, do the other. We may run in clinics that are so busy that you don't have time. So in this kind of setup, if a WhatsApp group is set up for you, you'll be able to discuss things, you'll be able to ask questions, not to just rely on Dr. Google, because then you may not be able to get what you need to do. Then the 4 types of diabetes are type 1, type 2, and type 2 has the most people. There's gestational, and then there's what we term as others, which could be due to drugs one has taken, especially steroids, if you take them for too long. So with whatever you will gather from this or these meetings, seeing that you will see different people or hear from different people, it will then enable you to be a person or a patient or a person living with diabetes who's able to manage without feeling that I'm not understood, because you're with your fellow people who also have diabetes. And you can also then go out into the community and be able to educate somebody else. So if you're helped, please help somebody else. It may not be with much, but just knowledge. When you see somebody else who's diabetic and you see their plate, normally it's not a matter of telling them, don't eat, don't do this. It's just telling them, how do I manage my sugar? How do I manage, living with this condition and not getting to a point where you're getting complications? So it is doable. And I would want to encourage the healthcare providers and the patients to always remember that although it is a lifestyle disease, it does not mean that it cannot be managed. It can be managed, and we are there to help you learn the tricks to manage it. Thank you.
Well, thank you very much, Dr. Nyawira. There goes the professional. So she will field questions. And I see somebody has already asked a question. Would you talk about gestational diabetes, Dr. Nyawira?
Well, gestational diabetes is found in pregnant or women who become pregnant and develop diabetes. Okay. Now, normally, and this can happen in any woman of childbearing age. The reason why we tend to want to manage them quickly and effectively is so that they can have an outcome. The baby and the mother are healthy. So the same follows. It's the same management like a diabetic, but we are more strict with women who are pregnant and develop diabetes, because after delivery, it can go. But in some, they become diabetic. So it is something that is manageable. All women of childbearing age ideally should know what their sugars are when they get pregnant. It's not a matter of saying, I am pregnant, I'm not diabetic, therefore don't bother. You may get to a point whereby you find you're diabetic, your doctor has not checked, and then things will not be as good. But it is manageable, and usually with delivery, it disappears.
Okay. I hope that answers you. Who was asking this question? So I can.
I have a question, please.
Okay, thank you. Thank you, Dr. Nyawera, for that. That's Lillian. I hope you're good with that. I hear a question from somebody. Please go.
Okay, thank you so much. My question just goes to Dr. Nyawera. Can she probably put more emphasis on the other types of diabetes that she's just talked about for the use of steroids? For the use of steroids,
Yes.
she can probably elaborate more.
Okay, what we mainly see in the clinics is people, especially asthmatics, who have been on prednisolone for a very long time, or patients who have allergies and take injectable steroids without having been explained the consequences of taking long-term steroids. We see patients who have been on prednisolone in our clinic for more than 5 years, and they're coming with diabetes. So the management of some of these diseases that are managed with prolonged steroid use, the patients should be warned, and steroid managing certain diseases long-term with steroids is not the right thing to do, because there are other forms of delivering the same steroids that will not affect your blood sugar.
Are you okay, Steve? Does that answer your question?
Yeah, that's thanks so much. That's okay.
Okay, very good. Do you have another question for Dr. Nyawera? Dr. Alice Ojong, you have a question for Dr. Nyawera?
No, I wanted to add on to something. Patients on steroids, but I found maybe especially asthmatic patients on steroids and are diabetic. And what we have actually found is your lifestyle, because if you don't sleep and you don't eat healthy, your allergy worsens. And so to control that allergy, they have to give you steroids. So even if whatever it is, whatever condition you are struggling with, if you don't manage the lifestyle, your doses of medication is always going to be higher. Yeah.
Okay.
Thank you.
Thank you very much. Stephen, double answer for you. So Lucy Bome also has a question. Please go.
Yeah, my question was about prednisolone, because sometimes back I had a problem with my chest. I was suffering from pneumonia, and then it advanced to bronchitis. And so that is among the drugs that the doctors were prescribing. The doctor was prescribing for me, prednisolone was among those drugs. So my question is, if they know that this drug can be able to cause diabetes, why do doctors prescribe this drug? Because it seems like I got my high sugars from this drug, because the prescription also went for quite a long time.
Okay, Dr. Nyawera.
Okay, thank you for the question. Now, at times what happens is, yes, being given prednisolone for a short time as it overlaps with the inhaled steroids is a better thing to do. But we do notice in a majority of patients, because they felt well with this pink tablet, they continue taking it. And unfortunately, our pharmacies do not talk to patients. So I go to the pharmacy and I ask for prednisolone, and the pharmacy will just give it out, because in this country, you know, unless it's a dangerous drugs that you have to have a prescription, anything can be sold to you over the counter. So we have found that a majority of patients continue taking the drug over and above the time they were given. But the ones who the prescription is being refilled, there are other methods, like I said, which should be utilized after one gets out of what we call the acute phase. The other methods are the ones that should be utilized.
Okay. Lucy, are you good with that?
Yeah. It's
For more
okay.
information, you can see Dr. Nyawera in her clinic.
Yeah, it's okay, but I just wanted to correct her that I would not go to buy prednisone on my own, but it was the doctor's prescription.
Okay.
Noted. Noted. Thank you very much.
And
Okay,
yeah,
good.
I just wanted to add something, and this is to do with ethics. Even and this is maybe to everybody and not particularly to you, Lucy, that we really need to talk to our doctors about the medication you're taking. You need to ask what the side effects are. We need to talk more to our doctors. They complain that we don't talk to them, so we need to talk more. We have Dr. Eben Jenga. Thank you.
Good evening, Alice and team, and this is an excellent forum. And I just want to mention something about the steroids. Of course, when Stephen Ari asked what about other causes of diabetes, and since you're going to be having sessions whereby you have many people talking about various types of diabetes, I think other than just the steroids causing the diabetes, we also have other people coming with other endocrine conditions like thyroid or pituitary diseases or adrenal diseases, and coming with high sugars, and also pancreatic tumors and so forth coming. So it's not just a straightforward, just the three types of diabetes. But what one needs to know that once you stabilize these other conditions, the sugar also settles. So it's not really like a permanent damage to the beta cells of the pancreas. But having said that, let's not, the lady who said, why do doctors prescribe steroids? Let me tell you, steroids are both evil and like the magic drug. It is an anti-inflammatory drug, and a doctor will prescribe the steroid when it's needed, and especially with asthma, even with very severe rheumatoid arthritis, where the inflammation can only be calmed by the steroid. However, it is the duration of the steroids, the dose of steroids that can sometimes taper off or cause the insulin resistance that gives you the high sugar. But as the steroids are tapered off and you're weaned off, most people, 99% of the patients, people with high sugars, it will revert back to normal because the pancreatic cells, again, will pick up after the suppression by the steroids. So there are times when you really, really must take the prednisone. There are people with the adrenal insufficiency who have to take steroids, and those ones, we have to reach out and keep monitoring very closely to see how the sugars are and manage them as they come. So it's not that steroids are evil. They are really, really good drugs and lifesavers. And there are times when you really even have to give them intravenously to save a patient's life. So I think it's important that, as you said, whatever medication one is prescribed, is good for either the prescriber or the pharmacist to take time to explain to the patient about the side effects, how you get to know that you're getting these side effects and what you can do. Speaking to your health provider about those side effects and when they come, and speaking them being peak tally will save and really reverse your blood sugars from very high to back to normal and get you back on to the non-diabetic state. And there are also then those people who are pre-diabetic who can be tipped over by the prednisone, so that even after you have removed the prednisone, the sugars remain high. But again, with the management, team management we are talking about here, we have seen so many cases go into remission. So I just wanted to let people know that please don't demonize steroids because they are lifesaver in certain situations. Thank you so much.
Thank you very much, Dr. Eva Njenga. And I know we have a lot of questions coming up for you. I think we'll field that as we finish. So for Richard, Jane, and Dr. Mary Mugambi, please hold your questions. The doctors will be there to answer. But for now, we keep talking about reversing diabetes, managing diabetes, getting a lifestyle that works. Is it a real story? Do they work? Does it work what Dr. Alice or Dr. Nyawira or Dr. Njenga are telling us, that we can actually reverse diabetes type 2 or manage our diabetes successfully? So let's listen to some real life stories. And to start us off, I think we have Ernest. Ernest, are you ready to tell us your story? And we just keep it brief and let's get the highlight of the story for everybody to get.
Good evening, everyone.
Good evening.
Good evening, Ernest.
Yeah, this is Ernest. I was diagnosed with type 2 diabetes on 16th of December, 2021. It's now roughly about 1 year. I didn't know that I had diabetes. Well, I was having issues with my eyes. Like I could not see far. Then of course, like blood vision, something like that. Then eventually, by the time I went now for the diagnosis, I was actually, feeling thirsty, passing urine every in less than an hour. You'd have to go to the toilet, to relieve yourself. So I went to see a doctor, and of course I was diagnosed with diabetes at that time. When I went some tests, everything was HH. It was too high. And the worst part was that there was also pressure. Pressure was quite high. We are talking of 161 over something like 133 at that time. So after doing the test, of course, they had to search me, look for me in the hospital. When they saw the results, able to put me on insulin. So I was on insulin for 1 month. And then that's when I was now referred to a diabetologist after 1 month, and the nutritionist, Dr. Juang. So I realized that diabetes management, at that time, my weight was around 109 kilos. I've managed to bring it down to 90 kilos, but I'm still on journey to reach 80 kilograms. I realized diabetes is a lifestyle disease in the sense that much as I was using insulin much as I used insulin for a month, my readings when I was taking the blood sugar was around 19. Then later on, I was started with some drugs for blood sugar, actually 3 drugs. And of course, I had one for cholesterol and then one for pressure to management. But much as I was seeing a diabetologist, physician diabetologist, I was also referred to the nutritionist. And I realized much as I was using the drugs, most of the work had to do with what I was taking in. I saw a question by someone about fruits and juices. And I remember I asked Dr. Juan some other time that, well, I thought taking juice was healthy, but since juice is a processed thing, then it spikes the sugar so fast. So those are some of the things that I learned, that you're better off eating fruits, chewing them and, undergoing the normal digestion. So apparently when I did my test of A1C, I realized that I was actually now about 6.1. That is about 2 months ago. And the 3 drugs of the 3 drugs that I was, one is a combination that is 2 drugs in one, and then another one is just a blood sugar drug. They've reduced one, so I'm left with the combination. For the pressure, of course, is also reduced to a lower value, and not a strong drug. For the cholesterol, they've also reduced the dosage from 40 milligrams to 20 milligrams. I have actually been strict on food because the last time I did that, I was actually told I'm good enough to actually leave the drugs. But because I've actually made, I was good enough to leave the drugs because I'm managing my sugars. Like my breakfast, when in the morning, it's usually about, when I wake up, it's around 5 point something, 5.1, 5.2. That's where I get the fasting blood sugar in the morning. And food is something that is very important because, you know, I've been actually taking the blood sugar tests, you know, like after meal and in the morning. Of course, right now I've reduced the frequency of taking the blood sugar test. But I was taking it initially when I didn't know how to, you know, like how the portions of food that I was to take and the type of foods that I was to take. As Dr. Juang said, is that I thought I thought beans, you know, legumes were more of a protein. So I would have my quarter rice because I was using the plate to measure what I eat. So I would have a normal standard size medium plate. I put a quarter of my carbs there, a quarter of my protein, and then half of it is vegetable. And I would actually monitor that and also take measurements for the blood sugar. And I would, eating different foods would actually give me an idea of which foods would actually trigger my sugars to go high. Right now, I would say I'm actually doing very well. Everything, like when I take my sugars, they're low. I'm also doing exercise, and it's not difficult exercise. It's not like I go to the gym. I basically walk, brisk walking, because I was told rule number 1, your food. Rule number 2, exercise. Rule number 3, reduce your weight, because I was obese. Okay, so to reduce my weight, I'm doing very well, and I'm actually doing exercise. I walk 10,000 steps on a daily basis. 10,000 steps is actually 10 kilometers for my based on my steps, because 5,000 steps is about 5 kilometers. So I go 5 kilometers away and 5 kilometers coming back. That is 10 kilometers on a day, brisk walking, and that has really helped. Initially, when I used to start, it was difficult, but now it has become routine. I don't strain. I don't have muscle pains. I used to have things that felt more like muscle pull, but they were not muscle pull. I think I was stressing myself. I was training, but right now I'm relaxed. My blood sugar has gone down, and I'm happy. Basically, I would say I'm free, but of course, I'm free, like just waiting for a green light from the doctor to tell me now you're off the drugs. Yeah, off the drugs. Once I do my test again, because I still have an appointment in April, I still so that they tell me you are now off the drugs. But I've really managed to maintain a low blood sugar for a long time, and all thanks to the drugs are there to help. But you'll only use the drugs if you are not doing right with the food. If you're handling it right with the foods, I don't think drugs would be an issue. I think something that's also, when I was first diagnosed with diabetes, because what I knew about diabetes, one was that it was a death sentence. Okay, because I've seen people with diabetes who eventually turn into complications of kidneys and so many other things, limbs being chopped off. So when I was told I was type 2 diabetes, I thought that was the path I was going to go. And then, of course, there was the issue of the people I knew who had diabetes used to eat a different diet. Like they would eat brown ugali, eat vegetable. And I thought, is this the lifestyle that I'm going to lead? Then I was told, you can eat anything. You can eat anything as long as you know what you are doing. In moderation. And there are times when you have to, give your body a shock. You can give it a cake once in a while, but you have to know what you're eating and when you're eating and in what portions to be able to manage diabetes. So it's important to know your foods. and eat right and be disciplined, because in most cases you are alone, so nobody is looking at you. But what is important is do the right thing as you're being told, and you'll find that life would be good. Luckily, I eat with everyone in the house, so I don't have special food for myself. Thank you.
Well done, Ernest. Well done. At least that shows us that it works. It's a program that works. So Rumesa is asking you, how do you feel now that the treatment, diet, and lifestyle measures have been in force for a while, Ernest?
Well, I feel a bit energized and happy. Like you know, in the office, people would tell me, whatever you are doing, continue doing. It seems to be good. Actually, your appearance, confidence, that can be seen. You find that you have more energy. Actually, when I was reducing these portions of food, that was difficult. Difficult not because it was the quantity of food that I was eating. I didn't have to eat a mountain of ugali or a lot of rice or a lot of fries or something like that. Just a small portion. And with time, your body adjusts to that, and it is more than adequate. And then, of course, let us not forget about drinking water. You have to take at least 2 liters of water on a daily basis. It is good for your body. It's good for your skin. I think it's good. I feel happy. I feel nice.
Great. There you have it, Rumesa. He feels good. He feels great. He's having the time of his life as he manages his diabetes, or as you wait for it to reverse. And all the best, Ernest. We wish you the very best in your program.
Thank you.
Good. So Richard, I had stifled your question, so I'll take that so we don't fight later.
Yeah, so I just wanted to make a comment about steroids and why doctors made mistakes or anything, and I posted it. I'm a diabetic. I had COVID in 2021, and I got very big doses of steroids. And the doctor made it clear that in their work, they weigh the risk of prescribing or not prescribing. So at that point, the risk of prescribing steroids were way lower than not doing so, even though I was diabetic.
Okay, Richard, did you finish or we lost you?
We can hear him. I don't know if, sorry.
Can you hear me?
We can hear Richard. Yeah, Richard is very audible.
Yes, very clear.
So although my sugar level shot up to about 25 during the period, but they managed it, here I am. My sugar levels are back to pre-COVID conditions. So it saved my life. So I don't think when doctors take certain decisions, they do it deliberately to ignore your existing ones. I think they are just managing the health risk that you may be presenting. The important part is to disclose what all known health conditions you have. That is very important because that influences how a doctor then manages your condition. Now, back to my own story. I've been diabetic for 15 years. I met Alice in 2011. She may not remember, but she was doing a free show somewhere outside the Stanley. Free. People were walking in and she was talking about, how to manage blood sugar, doing free testing. And she was also having some dummy of a plate and where vegetables should be, where protein should be. And that was very powerful for me at the time. So when my insurance was declined because of high blood sugar, I got tested and I met my doctor, Dr. Kunyiha at Aga Khan then. It was very devastating. But that demo by Alice Ojwang, I happen to have known her from our college life. She may not even remember it. I was with my wife when that demo was being made. And my wife focused on what did Alice say, that is what we should be able to do. Okay. So my 3 months AIBC in 2011 was 7.8. My highest IABC, except for period of COVID, has never been more than 6. I've always been on only one medication, and that medication is 50 grams of metformin and 500 grams of Januvia. That's all. I'm 50, so I can't run as much, but I do a lot of walking. Briskly, I climb the hill once in a while. But psychologically, what does help? What my doctor told me is called Dr. Onen. Let your family people know your condition thoroughly well. So today it is my young girls who call me, my 10-year-old daughter who calls to say, what did you eat today? What time did you eat? Have you taken your medication? Did you take a walk? They become the immediate support around you. And the fact that they've accepted your condition, that gives you comfort that nothing will surprise them. So this session we have today is so important. It has worked for me. I've not reversed my diabetes, but I'm stable at 6. Average blood sugar is about 6. Sometimes I wake up with 4.7, sometimes it's a bit 7, sometimes about 6. So what my brother was saying, eat, but monitor your blood sugar with consistency. Over time, you'll be able to know what food, when you eat, your sugar is stable, which one elevates it, and you manage it that way and let your family people know as well. When you travel, you go to weddings or you go to funerals or something, please don't get there and you are too hungry, you end up eating anything that is available. Carry a snack in your small backpack in the car or in your bag, something that you know doesn't affect you so much, you can buy it. Avoid being too hungry, and then you end up eating whatever is available. That can be disastrous. Those are my personal testimonies. Alice Ojwang, thank you for that free counsel we got 12 years ago.
Thank you. Thank you. That's a very powerful one. Very, very powerful.
So you can remember it.
From Kenyatta University, yes. Thank you so much.
Thank you. I think he has justified what Dr. Nyawera and Dr. Njenga was saying about the steroids. We've seen what he's talking about, teamwork to sort out diabetes. And now that is the real life manifestation of the program that we're talking about. Now, we were supposed to have other people talking, but I don't see them here. I don't see Sarah.
Just
Sarah from the UK program. I don't see Sarah here. I can't hear her, I can't see her. And then there was Abdi. Abdi, are you here with us?
Sorry, Abdi was traveling. He said he might or might not, but next time, they'll come another time if they're not here today.
So thank you very much, Richard, for stepping in. I think you've done a good job of making the program flow as it was supposed to. Do you want to say something else, or is your hand up in error, Richard? Okay.
It's lowered. I want to give the rest a chance also.
Thank you very much. But thank you very much for your story, success story, and it worked from a free session. And so you can imagine what will work when you pay. Thank you very much.
I'll make a donation so someone can benefit. Thanks.
Thank you. Thank you for that. Okay. So now I see questions. Do sweet potatoes spike blood sugar? What about fasting? The juice story. All of this is answered. We are jumping the gun a little, but Dr. Ojwang is prepared to talk to us about that under the topic nutrition in diabetes management. So Dr. Ojwang, please answer these questions before we ask any more.
So I do my talk, which will last maybe 7 minutes, and then I answer the question. Is that all right?
Okay, go right ahead.
So I'm just going to share my slides. And what do you see? I think it is sharing a different slide. Okay. So carbohydrate intelligence. Okay. Oh.
It's okay.
So this is I want to give you tips for managing your diabetes, but also managing your weight and health. So I call it carbohydrate intelligence. Carbohydrate intelligence is a meal planning approach that will highlight the total amount of carbohydrates that you consume. The source does not matter. the type of the hydrate consumed does not matter, because a carbohydrate is a carbohydrate. And why do I say that? You see, when people are diabetic, you'll go to the supermarket and somebody tells you diabetic bread. Of course, when you're given diabetic bread, you're likely to take a lot, but it is still a carbohydrate and it becomes 100% sugar. So in my world of practicing nutrition for 23 years plus, there's nothing like a diabetic diet, diabetic bread, diabetic jam. They are still carbohydrates. The minute you eat it, it is still going to be converted to sugar the way fast, okay? So why carbohydrate intelligence? This helps you to control your blood sugar. And actually the trick most of these people have used is to really learn about the carbohydrates so that they know what to do. Like Ernest is so keen. You know, the day I told him your beans is your carbohydrate, we almost had a fight. We had to go to the internet and check what is the carbohydrate content of beans. Then he says, okay, I agree. And of course, because when you monitor your blood sugar, you know when you have not eaten right. It also helps you control weight, prevent other chronic diseases. For example, if you have high cholesterol and you take a lot of carbohydrates, you're never going to bring it down. You have to change that. And generally, when you eat healthy, you improve your quality of life. So what are the carbohydrates? Let me just hear by show of hands. Maybe people can post in the group, in the chat, just post what are carbohydrates? Which ones are carbohydrates? I'm watching the chat. Carbohydrates, carbohydrates. Okay, Lorraine, what do you see?
I see ugali from Kathy. I think it's only Kathy who knows. Or then I see white rice from Irene. I see chapati from Pat Nduhio. Potatoes from Lillian, chapati, Joyce, energy-giving foods, nyoyo, cassava.
That's a lot. So most of them are naming starches. So let's just say that all starches are carbohydrates. The ugalis, the potatoes, they're all carbohydrates. All your fruits are also carbohydrates. All your legumes, we classify them as carbohydrates because they are 60% carbohydrates, 20% protein, and then there are other nutrients. And of course, all your sweetened beverages are carbohydrates. All of them, they fall in the carbohydrate category. So your breads, your rice, your beans are carbohydrates, your sweets and cakes, of course, and your fruits are carbohydrate. Juices are carbohydrates. Also, smoothies are carbohydrates because you think, oh, I'm healthy, I can take a smoothie. But what happens, especially, let's talk about the juices. And there was a question like that. You see, if I give you 5 oranges, you cannot eat them. You will eat 2 oranges, you start having too much acid, you'll feel irritation in your tongue, you stop. But when you squeeze these 5 oranges and put it in a glass of juice, you can drink it. And so you can imagine how much sugar you're drinking and how much acid you're drinking. Sometimes it just takes me a few minutes to talk to a client and I know what the problem is. Because we take too much fruit thinking that fruit is healthy. Yes, it is healthy. And by the way, all the foods are healthy. The question is always the quantities that you consume is the cut. So it doesn't matter if you're diabetic or you're not diabetic. Juices are a no-no. Just take your fruit whole. When we say eat whole, we mean also take the fruit whole. Don't make it into a juice. And of course, smoothies, people will make their milk and fruit, and the same thing. Falls in the same category. You end up having a lot of fruit in your milk or in your yogurt, and that's a lot of sugar. You will not control your diabetes with that. And most of the time when you're diabetic and your carbohydrate intake is high, and especially your refined carbohydrates are high, then your blood sugars will be equally high. Studies have shown that even your HbA1c is going to be high. So you need to control, you need to eat carbohydrates, but how much are you gonna eat? Your sweets are carbohydrates, your pastas are carbohydrates, your milk, not the cheese, but milk is carbohydrates. So the low carbs, of course, things that don't have carbs are all your proteins and some vegetables, or most of them. Your natural oils like avocado and nuts and seeds, these are good for you to increase in your diet. But the confusion comes when people learn about calorie. You know, fat is 9 calories per gram. That means if you eat a lot of fat, the calories are a lot. And carbohydrates, the calories are 4 per gram, and protein. So what happened when people knew these numbers, then they decided, oh, let's have more carbohydrates because the calories are less. And that explains why we have too much calories. Of course, studying in at school, doing my undergraduate, this was the prescription you were told, 55 to 60% needs to be carbohydrates. So we, as nutritionists and health professionals, for a long time, we actually prescribed a lot of carbohydrates. But now we know better. My PhD study was about carbohydrates and fat. And actually carbohydrates is the problem. Fat is never the problem. So reduce your carbohydrates. Don't eat boiled. You see, people eat boiled things. You eat boiled vegetables, you're avoiding the fat. But you see, fat increases your satiety. So if there's no fat in the food, you get hungry a lot faster. So you can just fry your meat, your vegetables a little bit with oil or everything else, but the carbohydrates are the ones that need to go down. So let me remind you that diabetes is a condition that affects the way your body uses food for energy. So that means that your diet is very important in managing your diabetes, getting it into remission, or just giving you a very good control like Richard has shared with us. So I'll skip some of this, but there was a study that was done in the UK by somebody called Unwin. And what he did is he helped us to understand how carbohydrates impacts our blood sugar. And what he came up with is, if you eat 5 grams of carbohydrates, is equivalent to taking a teaspoon of sugar. In other words, you remember when you take carbohydrates, it becomes 100% sugar. So your sugar are likely to rise higher if you take carbohydrates as compared to fat and protein. And so the amount of carbohydrates you take can be counted into grams. And so if you take just 5 grams of carbs, it's like taking a teaspoon of sugar. That's like the impact it will have on your sugar. So I'll just give you an example. So this is a healthy breakfast. What most people think is a healthy breakfast. So if we classify this in terms of the carbohydrate content, you can see it's, cereals, toast, and fruit juice. Most people think that's healthy. But if you analyze the amount of carbohydrate there, you find that you have cornflakes will give you about 8.2 teaspoons of 4 teaspoons of sugar, milk, one slice of bread, about 15 grams, gives you about 3 teaspoons of sugar, and pure apple juice will give you about 8.6 teaspoons of sugar. So in other words, if you have a meal like this, you've literally taken 21 teaspoons of sugar in one meal, and this is just your breakfast. So definitely that's not good at all, and we want to avoid eating. These are like 3 carbohydrates in one meal. So if you want to be healthy and avoid weight gain and diabetes in the future, you need to start thinking about how much carbohydrates do I actually take. If you want to control your diabetes and be able to even drop some of the medication or the doses be revised, then you need to manage your carbohydrate intake. I'm not going to go into details. I'll just fast forward to, this is an example of ugali. This is ugali. So if you eat this much ugali, 63 grams of ugali, 200 grams of ugali has about 63 grams of carbohydrates. That's about 12 grams of sugar. But don't be scared. So just know that the more carbohydrates you eat, the more sugar you're going to take. And this is beans. You can see if you eat beans on its own, the middle one there shows you beans. Where is my cursor? I have 2 screens, so if I'm looking, this is beans. So that is just about 32 grams of carbohydrate. But you can see if you eat beans with ugali, that gives you 88 grams of carbohydrate. That's a lot more sugar. So you shouldn't eat double carbohydrates. So let's fast forward to examples of some plates that I took from my clients. So you can see, let's start with yes, this plate. So this is somebody eating 2 carbohydrates. So they have cassava and then they have plantain. So this is almost, this is 12 teaspoons of sugar plus 10 teaspoons. So 22 teaspoons of sugar in a cup. So in other words, what's your carbohydrates? This is a little bit better. And that is also better, but you see the person is still having 2 carbohydrates. They have bread and fruit. So it's better to replace 1 carbohydrate with a lot of vegetables. And you don't want to ever be found eating like this. You eat an orange, you eat bread, you take porridge. You cannot eat like this, my friend. 1 carbohydrate a meal. This is a much better plate. You have vegetables, you have like 2 pieces of chicken, and you have a piece of bread, a small carbohydrate. Of course, when you're in the program, we will educate you and give you prescription according to your weight, according to what your needs are. But this is general information. So in short, to conclude, all right? Number 1, watch your carbohydrates. And when you want to eat your food, you need to figure out, where is my carbohydrate coming from? So when you're diabetic, all of us, we had maybe growing up before we knew so much about health. You eat a meal which maybe has got your rice, has got your chicken and vegetables, and then you finish, you go have a bowl of fruit salad as your dessert. So as a diabetic person, as me and you today in this program, you have to decide, is my carbohydrate coming from the fruits or from the starch or from the legumes? So you don't eat rice and beans. Those are double carbohydrates. You don't eat chapati and dengu. That is double carbohydrate. So just remember, taking drugs without eating properly is like washing your hands and drying them in the dirt. Thank you very much. Over to you, Ms. Lorraine.
Well, thank you so much, Dr. Alice Sojourn. That's heavy. You can't tell me I've been eating githeri or eating rice like chapati and beans, and that is wrong. That's double starch or double carbohydrate. That's what you're saying, eh?
Mm-hmm.
Okay. Interesting food for thought. That's why it was called carbohydrate intelligence. And from here, I'm sure we have questions. So let's take a few questions as we wind up the show. So let's hear from, I think there's somebody who asked a question. Dr. Ojwang, sorry, this may not have been for you. It was for Dr. Nyawera, but it was from Dr. Mary Mogambi.
Mm-hmm.
It was very smart. So let me just look for it.
I can help you.
Yeah, for Dr. Nyawera, and I think Dr. Njenga, the question was about chemosteroids and inducing diabetes. So she says she got frustrated when the diabetologist told the oncologist that her steroid dose was very high. Could this have contributed to my getting diabetes? Dr. Nyawera, it was addressed to you.
Just to reiterate what Dr. Njenga said, that some of the steroids in some diseases, we can't avoid them.
Is it me who can't hear? Can you
Yes,
move close? Can you move close to your computer, please? Sorry.
What I'm saying is, just to reiterate what Dr. Njenga said, in some diseases, you cannot not avoid steroids because they're lifesavers. So yes, there are some cancers, there's asthma, there's arthritis, where steroids are used. And in some instances, very high doses have to be used. Now, we would not, it may have contributed, or there may have been prediabetes. We don't know. But eventually diabetes developed. But when these drugs are tapered down, the sugars are managed. In a majority of people, they do manage to get off But if there's genetics, if there's family history, some people do not. But the steroids, yes, was necessary at that point. But I'm sure in most patients whom we start steroids, even at high doses, even if we do a sugar, the sugar may be normal at that point, but we've not screened for prediabetes because one, there may be no time, or it may be an extra cost where the steroid is a lifesaver at that point.
Thank you. I'm sure, Dr. Mugambi, that should help. I have another question, but this is for Dr. Ojwang, I believe. Amina says she has 2 boys, 9 years and 7 years. It's kind of hard to control their diet. And my many challenges is morning sugar. So I think her challenge is morning sugar when I've done my best to feed them. Kindly advise what I should do in order to keep their sugar down, I guess.
Okay. Thank you, Amina, for that question. I'm sure it can be challenging, but it's really hard to prescribe what you need to do because it's general question. But ideally, you just need to learn. Children have to be taught to eat healthy. They have to be taught to eat vegetables. They have to be taught to eat their carbohydrates. And of course, they need sufficient energy to be able to grow because they are still growing. So you cannot restrict, but if you look at his plate, how much food is he eating? Are you serving carbohydrates? Are you serving a protein? Are they eating vegetables or you're feeding them? Because their habits now is going to affect their health in the future. They can become diabetic, they can become overweight and become diabetic. My heart always goes out when I have a child who's type 2 diabetes. It really depresses me. I don't even like to deal with patients. So just learn. And joining the program will help you to manage yourself and also to manage your family. We also have some YouTube videos on our YouTube channel and we'll be posting some. Maybe you can also watch that to help you. But you have to learn to teach your family to eat healthy. This is a plate that Richard was talking about. You see, half of your plate should always be vegetables, a quarter protein and quarter starch. So try practicing this. And once you finish all your vegetables and all your little protein and all your starch and you're still hungry, then you can add a little. But always start by eating like this. Even the children need to be taught to eat vegetables. A lot of times children have constipation and they have problems, and it's just because they don't eat vegetables and they don't drink water. So how much vegetables is your child eating? How much vegetables are you consuming? That determines actually your future health. I remember going for a conference in Dubai in 2011, World Heart Federation, and 2 things they said in that conference that scared me. Number 1 was fruit juices was called fructose, which is a fruit sugar, was called the next tobacco. And why did they say that? Because people abuse fruit. You eat so much fruit, you make so much juices, you have a whole huge bowl of fruit, and you think that's all. No, that's not healthy. The second one was the amount and type of carbohydrate on your plate is going to determine your cardiovascular health, which is so true because we can see what carbohydrate is doing. And remember, if the children get used to taking a lot of carbohydrates and taking a lot of sugar, they won't stop because you become actually a carbohydrate junkie. You're always looking for carbohydrate, always looking for some bread, always looking for some starch to eat. So we want to learn now to just eat healthy and live a long, healthy life. Thank you.
All right, very good, thank you. I think one last comment I'll take from Ernest.
Okay, it's just a comment to add on to what Dr. said, is that I remember there was one thing, apart from avoidable carbs, was that you must make sure your food is on one plate. That is rule, that's the greatest rule. So, because you're bound to overeat if you have food on separate plates. So ensure all this is on one plate. That's when you'll be able to manage your portions well. Thank you.
Thank you very
much. And you finally managed to do that, Ernest, remember?
Yes.
Yeah,
Thank you.
because We put ugali in another plate, and then we have meat and vegetables on another plate. Then sometimes we have tea and bread waiting for us after dinner. Hey, people. In fact, just watching your carbohydrate intake is really important, and it will help you. Yeah.
Thank you very much. Thank you. So there are more questions. Anthony will take note of them and we can see how to address them. However, I think the questions relate to how do you manage a diabetic athlete when it comes to carbohydrate intake? Another one, it's frustrating, again, I think from Amina, can Dr. Alice guide us on the best diet? Yes, she can. And it's all part of this program. And that is what Cynthia wants to tell us. What is the investment? So you want to hear good diet, you know what to do, it costs something. So Cynthia, tell us about it.
Good evening, everyone. My name is Cynthia. And as you have all heard what DCLP is and what it will do for you, the practitioners involved, as your support system for 12 weeks. So all we ask for you is those who haven't enrolled to enroll the program. And how do you do it? By committing to pay 30,000 shillings. 30,000 shillings will get you into the program, will get you into this 12-week program. We currently have a running discount of 5,000, so you get to pay 25,000. We have extended this date up to 13th of February this month. Our pay bill number is 522522. Of course, we shall share this information in all our social media handles. Thank you for this.
Thank you, Cynthia. It's worth the investment. I heard about all the doctors that are involved. It's like having one session and you're exposed to so many professionals and so much information. So please call Cynthia and make the investment. Thank you very much.
Did you put our numbers on the chat? Maybe Cynthia put our numbers on the chat so they can call you if they want to join the program. And the email address as well. Thank you.
And please don't forget to call Lillian Kipsang. She has a story for you, Cynthia.
Oh, all right.
Okay, good. Okay, so that has been interesting, hasn't it? We have learned so much. But we have a challenge, Alice. Are you giving us something? Although we are launching the program today, do we have a challenge for the next week?
They have a challenge, but the next program will not be available to you unless you pay. But the challenge is this week for you is, please, look at your plates. Take pictures. You know, you can share with us your pictures for the next 2-3 days if you take the number, and we will tell you bad, good, bad, good, bad, good. But remember, this is the plate. So the challenge for the week is start using one plate for your food. Like Ernest reminded us, most of us will get ugali on another plate and the rest on another plate. And stop having desserts if you're diabetic, stop eating snacks. If you're well controlled, you never need to carry around snack, even though it's safe to carry some nuts and something. But if you're well controlled, you'll never struggle with hypoglycemia and getting low sugars. So start eating like this. This is your what? Okay. Challenge number 1, start eating like this. Challenge number 2 is think about your carbohydrate intake. How much carbohydrate have I been taking? Start reducing your carbohydrate intake. Number 3, how much vegetable have I been taking? The more vegetable you eat, the less carbohydrates you actually eat. So make sure you fill your plate with vegetables and then start by eating your vegetables. And then you can eat the rest of your food. Vegetables, your meat or your protein, then your carbohydrate. Thank you very much. Yes.
Thank you. We must say a very big thank you to our panelists. Thank you very much, Dr. Ojwang, for getting this together, for bringing us all together. We're very grateful for the instructions. We're very grateful for the challenge and, you know, the information making us think about Thank you very much to Dr. Nyawera for the very, very important information. Thank you. We have to do this with the family, get a support group, get involved, get everybody involved so that we have accountability partners. Thank you, Dr. Eva Njenga. She's been the guru in this field for a very long time. Thank you for joining us and for adding your input to it. Now we know when the doctor prescribes steroids, there's a good reason for it. So let's keep going. So question as we finish, are you pre-diabetic? Are you diabetic? Or like all of us, are you susceptible to diabetes? Well, what have we learned from today? To do what you can with what you have where you are. Let's keep up. Let us join the program. Let us know what else we need to do so that we can manage and at least reverse, especially type 2 diabetes. It is a lifestyle illness and we can do something about it. Thank you so much for joining us this evening. We look forward to being with you next week. Same time, that's 8 o'clock every Monday evening for the next 12 weeks. Thank you. Good night, everybody.
Good night.
Sorry.
Good night.
Yes, you can speak freely for the next few minutes.
Thank you, Lorraine.
Thank you.
Thank
so
you.
much.
Thank you. Thank you.
We really need help when we have the small one. It's not easy.
So I think Cynthia will look for Amina. Please, Cynthia, make sure you get her.
So Amina, you need to see a nutritionist or dietitian. This is the work we do to help you. To help you with these things. This is our job. So find a dietitian, find Anthony, find me, and we will help you.
I will find you.
A mother who talked about 2 children, I'm assuming that those 2 kids maybe have type 1. That's someone you need to and support. It's quite, it can be very challenging.
Yeah, 2 of them, they
Yeah.
are type 1, yes.
So Amina, please, I'm looking forward to talking with you and helping you in this journey. So please call us and book an appointment and we can take it from there.
I will do it because I will use that number. I'm kindly frustrating. My life is in a mess. I need help.
We will work together to help you.
Thank you so much.
You're welcome. And thank you for joining us.
Thank you too for your time.
Thank you, team. All the best.
Florence, USA.
I have something to say. Hi.
Hi, please say.
How are you?
Bye, guys.
Bye, Stephen. Thank you for your
I just wanted to say
You're most
thank you
welcome.
and bye. I'll
Florence,
call you Alice.
Bye, Alice. Bye. Bye, everyone.
Bye,
What happened?
Thank you.
Okay.
Alice, what are you saying?
I said it was nice to see you.
I know. I missed the other one. It was full. So I promised I would log in. I sent you a message, so we'll talk.
Okay, thank you. This time we tried, we put YouTube. We can tell the Americans to donate dollars. Talk to Zoom to give us free.
I don't know anybody.
Thank you. Thank you. Thank you so much for joining.
All right, not a problem. We'll talk later. Thank you, dear.
Okay.
Bye.
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 Bye. I think there's somebody who asked a question on somebody who has hypoglycemia. But in case they're still here, if somebody is diabetic and they get hypoglycemia, it means the doctor needs to alter their medication or they just need to get their diet right, yeah. So we'll use these questions to actually do some YouTube videos, I think, yeah.
Anthony, you took them down and you took who wrote it. We can look for them, eh?
Yeah.
Okay, thank you.
Yeah. And Cynthia, a good thing to do is to actually put the link here so that guys can sign up. You remind them there's a link on the chat, so if you want to sign up, but it's okay. Okay, everybody, it's over. Good night.
Congratulations, Alice and Lorraine.
Thank you, Mary. Nice to see you.
Thank you, Mary. Always so supportive. Thank you.
You can see our students here, Brighton, Omondi, even though he's not here. I mean, Omondi is no longer a student. It's really nice to see some of our students here.
Thank you,
Okay,
Mary.
Alice and Maureen.
Bye.
Bye.
Bye. Bye.
Congrats again. Bye-bye.
Bye, Mary.
Yeah. Only the ones remaining behind. Bye.
Bye.
Okay,
I
bye,
can
Brian.
see somebody logging in now. Hmm?
Bye.
Bye.
Say hi, Jacinta, and bye.
Hi.
Hi.
Bye, Dr. Joan.
Sarah, are you happy?
Very happy. Today I managed to join.
I'm glad. I'm glad you did. Okay.
So Alice, do your thing.
I think I'll end it and then let's just quickly join for 5 minutes to review, yeah?
Okay.
But it seems like they're going. Okay, let me end and then let's join on the same link.